Hello, this is Eric again from Stanford University, and today I'll be discussing disorders of magnesium balance. Historically, the role of magnesium in human physiology has been largely ignored in most clinical circumstances, with the exception that everyone seems to love aggressively repleting it. The reasons we tend to ignore magnesium disorders is twofold. First, medical science has limited understanding of magnesium regulation compared to other electrolytes. And the second, we have limited understanding of the significance and frequency of derangements in magnesium balance. However, in this video, I'll summarize the extent of what we do know. Before discussing pathology, let me start with an overview of normal homeostasis. Of the magnesium in the body, about 50% is stored in the bones and about 50% is in the intracellular space. There's actually about 1% left over, which is in the blood. Of that 1%, 20% is bound to albumin, 10% is complex to anions like phosphate, and 70% is unbound, which is the biologically active form. The consequence of the fact that only a tiny fraction of the body's magnesium is present in the blood is that serum magnesium levels correlate poorly with total body magnesium content. Let's take a look at how magnesium homeostasis is regulated. As with all electrolytes, homeostasis begins in the GI tract, where orally consumed magnesium is absorbed, a process which appears to be dependent upon passive diffusion from the GI lumen through the tight junctions between epithelial cells and into the blood. Similar to calcium and phosphate homeostasis, the bones act as a reservoir for huge amounts of magnesium. Unlike calcium and phosphate, however, the magnesium in the bones is not in a tightly regulated equilibrium with the blood, and the bones do not have nearly as important a role in magnesium balance. Magnesium is freely filtered through the glomeruli of the kidneys, where most is reabsorbed again in the thick ascending limb of the loop of Henle. As with the gut, most magnesium transport in the kidneys is due to passive diffusion between cells down an electrochemical gradient, which itself is partly generated by reabsorption of sodium and chloride here. It is also dependent upon a paracellular protein called Claudin 16, which is a constituent of the tight junction between epithelial cells. Overall, there are no known hormones or enzymes that directly regulate magnesium balance. That's not to say there aren't any, just that we don't understand them yet. However, what regulation we do know about occurs mostly in the renal tubule, where a number of metabolic derangements affect magnesium reabsorption. Derangements which prevent reabsorption and thus lead to hypomagnesemia include low potassium, high calcium, high magnesium obviously, and finally low serum pH. This is a good time to transition to hypomagnesemia. As hypomagnesemia is rarely seen in isolation from other electrolyte abnormalities, it's difficult to attribute specific symptoms to it. Most symptoms are thought to actually be caused by secondary abnormalities that are frequently associated with or even caused by hypomagnesemia. For example, concurrent hypokalemia can lead to cardiac arrhythmias, while concurrent hypercalcemia can lead to neuromuscular irritability, which can manifest as tremors, fasciculations, and tetany. Whether hypomagnesemia in isolation can cause these problems as well is actually not entirely clear. In addition, there are some epidemiological studies that suggest a link between chronic hypomagnesemia and both hypertension and coronary artery disease, though a causal relationship has not yet been clearly established. In a similar manner, despite occasional claims to the contrary, there are probably no specific abnormalities of the waveforms on the EKG that are specifically suggestive of hypomagnesemia. However, there are conditions in which hypomagnesemia is associated with an increased risk of ventricular arrhythmias. These include acute myocardial infarction, prolonged QT syndrome, congestive heart failure, and digoxin toxicity. Hypomagnesemia also increases the risk of AFib following bypass surgery and may also increase the risk of AFib in the general population. Somewhat surprisingly, routine repletion of magnesium post-CABG has not consistently been found to be beneficial. There are a large number of causes of hypomagnesemia. The first general mechanism is decreased GI uptake. This obviously can be due to just poor dietary intake, most commonly seen in alcoholics. It is also observed in patients on PPIs through an unknown mechanism, or more appropriately, through a not completely understood mechanism. There is also a very rare disorder called primary familial hypomagnesemia, the specific genetics of which are not yet fully worked out, but which presents in infancy as hypocalcemia that's responsive to IV magnesium therapy. This secondary hypocalcemia is believed to be due to the effect of hypomagnesemia lowering PTH secretion and increasing PTH resistance. This effect is explained in a little more detail in my video on normal calcium and phosphate physiology. Magnesium is also present in proximal GI secretions, which normally are largely reabsorbed later on in the GI tract. However, in patients with chronic diarrhea and malabsorption, and those with extensive inflammatory bowel disease, this reabsorption can be reduced to the extent of causing deficiency. By far, the most varied general category of etiologies is renal losses. Renal losses can be from medications, most often loop and thiazide diuretics, but also amphotericin B, aminoglycosides, cisplatin, and calcineurin inhibitors are all classic causes of hypomagnesemia. As mentioned earlier, hypercalcemia and hypokalemia both inhibit magnesium reabsorption in the renal tubules. Any process that causes a prominent osmotic diuresis may disrupt the electrochemical gradient driving magnesium reabsorption, which can be seen in uncontrolled diabetes and during a post-obstructive diuresis. Alcohol is thought to cause transient tubular dysfunction, which contributes to the nearly ubiquitous hypomagnesemia seen in severe alcoholics, in addition to their usual low PO intake. Finally, there are a handful of rare familial renal magnesium wasting syndromes. The most widely known is Gittleman syndrome, an autosomal recessive disease caused by a defect in the thiazide-sensitive sodium chloride cotransporter in the distal tubule, which also results in hypokalemia and a metabolic alkalosis from secondary hyperaldosteronism. There are also a number of highly rare genetic defects affecting the Claudin 16 protein, which lead to a syndrome of hypomagnesemia, hypercalciuria, and nephrolithiasis. Lastly, in the miscellaneous category is pancreatitis, where magnesium and calcium salts can be involved in the saponification of retroperitoneal fat, and magnesium can be quickly drawn up from the serum in the hungry bone syndrome, described in a little more detail in my video on hypophosphatemia. Moving on to the diagnostic evaluation of hypomagnesemia, it's actually pretty easy, as the etiology is usually evident from the patient's history. However, if it's not, one can calculate the fractional excretion of magnesium. This is calculated as the product of the urine mag concentration and the plasma creatinine, divided by 0.7 times the plasma mag times the urine creatinine. This is all then multiplied by 100%. The 0.7 term here accounts for the fact that only about 70% of circulating magnesium is free and is able to be filtered across the glomerulus. If the fractional excretion of mag is greater than 2%, it suggests excessive renal losses. If it's less than 2%, it suggests GI losses. This calculation is rarely done in routine clinical practice. When it comes to the treatment of hypomagnesemia, on one level, it's simple. Just give magnesium. On another level, though, it can be a little tricky if one doesn't think hard enough about the situation. One reason for this is abrupt increases in serum mag, as seen during IV administration, inhibit mag reabsorption and lead to transient wasting, which is obviously counterproductive. Therefore, in the absence of symptoms, arrhythmias, or concurrent hypokalemia, which greatly predisposes to arrhythmias, oral repletion is usually preferred. On the other hand, if any of those are present, IV mag can be given, usually 1 to 2 grams of magnesium sulfate at a time. Although it's a common practice to give IV mag relatively quickly, that is, over less than 15 minutes per gram, this speed is usually not necessary and may even be undesirable. A practical question that frequently comes up, and which is literally never mentioned in the literature, is what should the goal magnesium level be when undertaking repletion? In the US at least, it's common practice to replete serum mag to high normal levels, that is greater than 2.0 milligrams per deciliter. This practice is not based on strong evidence or guidelines, and it's probably not necessary for most patients. Possible exceptions to this, that is, patients to still replete above 2, include those with acute MIs, those with active arrhythmias, and those with long QT syndrome. And please remember that one of the most common causes of hypermagnesemia, as we'll see in a second, is iatrogenic excessive repletion in patients who are either elderly and or have renal impairment. So therefore, please be careful with both the total dose and the rate of repletion in these patients. Let me now move on to hypermagnesemia. Because hypermagnesemia is often more abrupt and iatrogenic, it's easier to demonstrate that some findings are truly due to hypermagnesemia and not from other concurrent electrolyte disorders as with hypomagnesemia. These clinical manifestations fall into two main categories. Cardiovascular manifestations include bradycardia and conduction block, which can progress to complete heart block and even asystole, along with hypotension. The other category is neuromuscular findings, which include decreased reflexes, muscle weakness, drowsiness progressing to coma, and signs of parasympathetic blockade. These signs include cutaneous flushing, dry mouth, dilated pupils, and urinary retention. The etiologies of hypermagnesemia are pretty minimal. First is renal failure. The kidneys are the only known place in the body where magnesium levels are sort of regulated, and if they aren't working properly, there is no way for the body to get rid of excessive magnesium that it may have absorbed from the gut. The next mechanism of hypermagnesemia is simply excessive mag administration. This can be in the form of massive PO intake from the laxative magnesium citrate or from Epsom salts. It can be from excessive IV infusion, which can be seen during the treatment of the life-threatening obstetric condition of eclampsia, in which appropriate treatment almost always results in supernormal magnesium levels. And finally, can be from magnesium-containing enemas, particularly when used in a patient with concurrent renal impairment. And in fact, magnesium-containing enemas are contraindicated in that situation. The only significant miscellaneous mechanism is tumor lysis syndrome, in which a very large number of cancer cells, either spontaneously or in response to initiation of chemotherapy, suddenly die and break apart, releasing a large amount of intracellular magnesium, and in fact, all of its intracellular contents. In general, the hypermagnesemia from this will be a relatively minor issue as compared to the hyperkalemia. The diagnostic evaluation of hypermagnesemia is the easiest of all electrolyte abnormalities, as the etiology is almost always evident from history and review of renal function. I personally have never encountered a patient with hypermagnesemia who required any diagnostic evaluation beyond cursory chart review. The treatment of hypermagnesemia depends upon the patient's renal function. If it's normal, the typical treatment is simply to stop the causative magnesium-containing medication. If the patient has chronic kidney disease with a GFR on the order of 15 to 45, or has non-anuric acute kidney injury, a combination of normal saline and furosemide should be sufficient, with solid attention given to maintaining appropriate volume status. If the patient has chronic kidney disease with a GFR under 15, or has anuric acute kidney injury, the only way to get rid of the excessive mag will be dialysis. Finally, in the setting of acutely life-threatening hypermagnesemia, IV calcium may temporarily antagonize the activity of the excessive mag. It's possible that in another 10 or 20 years, we'll know a lot more about this electrolyte, but from a clinical standpoint, that's all there is to say about it right now. If you found this video interesting and useful, you may want to check out my similar videos on calcium and phosphate disorders, or the upcoming videos on sodium and potassium disorders.